We're live. Hello, everybody. I am Michael Meneghini, orthopedic surgeon and author of The Incision Point here on Substack. So it is my pleasure to have a conversation today with Dr. Tony Sorkin, who's also my partner. Tony, welcome to Substack.
Thank you.
If you don't mind, just give us a little history about yourself. I mean, one of the topic we're going to talk about today is value-based care and what it means. I know here in Indiana, it's miserably cold and wet. So it's a good day for a 1 o'clock conversation about value-based care.
Yeah, on a holiday weekend.
Yep.
Yeah.
So tell us about yourself. Yeah, tell us about yourself and your experience in value-based care, and then we'll dive right into it.
Sure. So I'm an orthopedic trauma surgeon and started off in private practice in what is now Ortho, Illinois. But back in the day, we used to call ourselves Rockford Orthopedic Associates. And started diving into, in this area, what we're talking about today, hospital co-management agreements and the early days of trying to figure out how to bundle things like carpal tunnels and stuff like that at our surgery center then. And that goes back, see, I've been doing this 27 years, so that goes back to the mid 2000s. And then you recruited me to come down to IU, and from there, started working with the orthopedic service line. Obviously, CJR became an issue in 2015, 2016. And then moved over to population health, started working around the ACO and some of the Medicare Advantage stuff, especially on the post-acute side. And then you became an expatriate, and then I became an expatriate for Big Health, and now we're in practice together and concerning ourselves with running an ASC-based practice, which is a whole topic there.
Yeah.
And now we have CJRX that our hospital partners are going to have to contend with.
Yeah, I love it. Love it. Well, thank you for that. And look, the good thing about talking about value-based care with experts like you who've got such a tremendous experience is you can share with the people who watch this video and who tune in, and even those that are on live now will hopefully provide some tips and tricks to succeeding. And let's start with Tony, just what your thoughts are in general about surgical proceduralists and what it means to say the word value-based care. I've been hearing that word for 15 years, and it has a lot of different meanings. But in 2026, as we see the world, and we'll get into the ASCs for sure, what does value-based care mean to you for people tuning in?
Well, I think, and it means a little bit something different to everybody, depending if you're the payer, if you're the hospital president. But I really feel like in this iteration, what CMS is trying to do is convert claims to quality. They're trying to, claims data don't tell a story at all, and so they're really trying to incentivize physicians to manage their quality. And of course, they're using the hospitals as a whipping stick. And so traditionally, not many surgeons, I bet 20 years ago when I was in my first 5 years of practice, nobody was in our office wondering what our percent utilization was of a SNF, right? It just happened, nobody cared. And now suddenly they want us to care. And they want us to care enough that they're offering both upside and, of course, downside risk, especially with this new CJRX program.
Yeah,
so I think that's a motivator. But it really, the funny thing is the DRG program was actually created as one of the initial attempts to have a value-based care product in Medicare, starting with that. And so here we are now. The episode of an event is not even really part of the value-based care. That's hospital margin, and we can talk about that too. But really today, to answer your question, the proceduralist today, whether you're in team or CJRX, it's the post-acute piece, and they want the physicians to manage that a little more closely.
So you mentioned two words that I hear a lot, and for the people who are going to watch this, help me and them understand it. Upside and downside risk. Walk us through what that means.
Yeah,
so hear it a lot.
Well, if we can just stay at 50,000 feet for a second. So the CMS will determine how much an episode should be. And if we can just live in hip replacement for a second,
Yep.
under CJRX, through a series of mechanisms, will determine what the history is of a hip replacement at your hospital. And then they will take a discount, the amount they want to save, and then they will look at your next year's worth of experience with a hip replacement. And if you spend more than your historical average, then you owe them money. And spend meaning 90 days, if we're staying with CJR,
Yep.
90 days of care. If you spend less, if you are managing things more closely, then they will send you a check. So that's the upside downside risk. Now, it's the hospitals that are actually managing the money. They're the entity that are financially
Called the conveners, right? Called the
right.
conveners, right? Yep.
And it's oversimplified. So the history is not your personal history;
Yeah.
it's regional, and it's a little different. But we could get into that. But that's really what it is. You have 5 physicians doing hip replacement at mid-sized hospital right now. It's the CJR program is mandatory. You're involved, and they're going to start tracking your. We call it outcomes. That's what we want it to be, but really your spend. And the hospital's responsible for the upside or downside. And the good part about CJRX,
Yep.
is that the hospital can choose to gain share with the physicians as a motivator. And explicitly now they're saying you can gain share. And it's not just with the physicians, you can gain share with other entities that are affected by the bundle as well.
No, it's a great point. And I was going to ask you, if I'm an orthopedic surgeon or any surgeon, particularly orthopedics, because it's in the it's in CGRX or the bundled program by CMS. If I'm an employed surgeon, I'm sitting there and someone says, well, CGRX is coming. What do I need to care about? Like, if I'm getting paid by a hospital, do I care? Or do you think right now they're like, I don't care, but then pretty soon a hospital administrator is going to knock on their door and they're going to say, hey, it's time to put our CGRX program together. Right. I mean, what do you think? What does that look like if we were still back at our old institution, a hospital? What do you think is going to happen to the employed physicians? Are they going to get aligned? What do you think is going to happen?
Well, I think it's hard to tell because I think, honestly, in big health right now, I'm not so sure that this is a risk that they're going to want to spend money on. All right, I'm not sure has. They probably have deep enough pockets that some of them are just going to say, we're just going to keep doing what we're doing. If we win or lose, it's not going to be that much money.
But some of the ones that don't have deep pockets might
For,
tune into this, right?
for somebody that doesn't have deep pockets, a $600,000 bill at the end of a year is substantial. If
That's right.
if you're a non-for-profit making 10 billion a year in net revenue, you probably don't care.
That's right.
But let's agree that they're gonna care because it's better quality. And so then, in your example, a committee will get formed,
Yeah.
and they'll meet periodically and they'll talk about ways to try to win. And in our experience, most of the time, those committees are not fruitful, not understanding really what's getting tested.
And this starts CGRX, the mandatory bundles in the United States. And if you're not in the other bundles that were released called Team, Transforming Episode Model, if your CGRX starts October of 27, correct?
Yep.
So a little over a year for everybody to sort of get their ducks in a row, as we say, to get ready to perform. And then the money exchange will be at the end of 28 or probably the early 29, correct?
It always takes longer than they assume, but you got to let the claims run out. And so it's not immediate gratification.
Yeah. Right.
Yeah. For sure.
But performance will be tracked. So, all right. So that's the bundled team. If let's look at our group where we have 10 hip and knee surgeons and we're an ASC based group. Do we need to care about value-based care? So those private practice groups that are out there, we're like, hey, most of our stuff's in ASC, in ambulatory surgery centers now. The hospitals are the conveners. Do we need to care about value-based care?
Well, specifically in our ASC, in regard to the CJR program, no, because it doesn't include ambulatory surgery centers. However, we have our own value-based care group that you're a part of.
Yeah.
And when you start looking at what are the opportunities to actually save money. In general, ambulatory surgery centers cost about 65% of an inpatient surgical episode. And so, as you go to a payer, and you can say, as we do, 95% of our primary hip and knees are done at a surgery center.
Yep.
So that's very appealing for a payer, as opposed to if you're doing 95% of them as an inpatient. So, and so that's why I'm working on, and our partners all agree this is very important, because we can, as we start developing direct to employer relationships, working with work comp vehicles and private payers, we're able to show that we are a high quality and low cost. And then I think coming soon, most people agree that Medicare, right now there's a huge shift. I think something like 35% of primary hip and knees for traditional Medicare are done on the inpatient side.
Yep.
So if you're watching this and you're at a hospital and you do 1,000 inpatient joints, the government is looking right at you
Yeah,
to get out of that hospital.
That's right.
Most of the joints are done in an HOPD, which is something that was kind of created by hospitals to do some cost shift out of their inpatient. It's still 90% of an inpatient cost.
Yep.
So it's not really much savings, but they call them, as you know, especially in Indiana,
hospital outpatient department. That's what they call them.
Yeah, but they call them surgery centers, and everybody thinks it's an ASC, but it's not.
Right.
And then about 15 or 20% of traditional Medicare joints are done at an ASC. So what I would say is that you want to shift all of that volume to an ASC, and then you want to excel. So what we tell our partners is that this is going to be one of the fastest growing markets in the United States, is surgical episodes that are started in an ASC.
Yeah.
I would assume by 2030. By 2030, Medicare says everybody's going to be involved in some sort of value-based program, every traditional Medicare beneficiary, but the surgery center is going to be a part of that.
And the way I think of it, Tony, correct me if I'm wrong, is when you think about value-based care, in its most simple form, it's lowering cost and either maintaining quality or improving quality. The goal is to improve the quality of care. At the end of the day, it's to provide value to the patient, provide value to the healthcare ecosystem, most importantly, value to the patient, which means provide great care at a lower cost. And I think if you look at ambulatory surgery centers, I think there's really clear data now in hip and knee replacement that just an ASC and moving your patients to an ASC, because the quality is probably improved slightly and the pay is dramatically or the cost is decreased, is a value-based care endeavor, even in and of itself, probably. Wouldn't you agree?
Yeah. Well, and specifically, a large chunk of surgery centers are owned by physicians, which is different.
Yeah.
So, and both in my past life in Illinois and then in here, there's a mindfulness, because it's the dollars of the employers that are managing this, and so, and we see it all the time when you talk about margin. Sitting at somewhere in big health or even a mid-sized hospital, some new Twinkie comes out and we're going to try 10 of them at 10 grand a piece. And nobody thinks about the cost of that. And even from the supply chain days. And so there is very little to no experimentation when you're the owner of an ASC, because it comes down to the margin. And so I think the ASCs also, to be fair, creates this mindfulness. And then you don't have that. You and I have sat on committees in our past life, and everybody wants to pay attention, but it's the financial exposure. If you want to look at it this way, upside downside of being mindful of the implants. We did a program during the original CGR that worked, but outside of that, they're not really too happy about gain sharing on that aspect in a bigger organization.
Yeah, I want to talk about two things here before we get on to something different. But let's talk about the post-acute care. In our original world, we used to spend a ton of time. The first migration of cost savings in the original CJR, the original bundled Medicare, for those on the watching this, CJR originally was the original 90-day bundled payment program for hip and knee replacement in 13 of the biggest markets in the United States. Indianapolis, where we are, was one of those. And they would, and that program did very well. And as I recall back then, 11 years ago, the big cost savings was to minimize post-acute spend, which was a combination of making quality so we don't have readmissions and reoperations, and also avoiding the what we call the SNFs, which are the subacute nursing facilities or the rehab facilities. Is that still going to be in play as much as an impactful in this new 2026, 2027 after we made some improvements? What's your thought on that nationally?
Right. So nothing has really changed. There's a heavy lift on the post-acute side, and luckily, since a large majority of these joints now are done either HOPD or at an ASC, there's less exposure to facility for kind of an inpatient stay facility,
Right.
so homes. And certainly, if any of your patients are getting sent to an inpatient rehab facility, um, uh, or a critical access hospital for one of their rehab beds, you should avoid that at all
Yeah,
costs.
that crushes the
That's
bundle.
double the cost
Yeah,
of
that destroys the bundle. They used to call them
that's
back in the day. We used to have the term bundle buster, right? And that's
right.
exactly
Yeah,
what that is.
yeah. So now it's a little more refined, I think. And I'm not a hip and knee surgeon, but so I would ask you, I mean, what percent, I mean, I know the answer, but what percent of your hip patients get 4 weeks of physical therapy?
Yeah, for
Right.
us,
It's
it's
probably
zero, right? Yeah, we don't do physical therapy for hip,
right. And
right?
so, but 20 years ago, 100% did,
Yeah,
and so avoiding home therapy, home-based therapy, that's a whole nother cost that is borne by that can also tear apart
yeah,
a bundle. So I think there's that whole post-acute side. So you can avoid it by avoiding the big drivers. But then when you look at hospital ER re-encounters and
yep,
readmission, a, a very large majority of those are due to they occur in the first week,
yep,
and it's pain management issues, nausea, and hypotension.
yep,
And so what we've learned is that a huge chunk of that is due to your anesthesia provider. And so there's scales to this. And if you're at an HOPD and you have a typical anesthesiologist who's just used to what they do in regard to kind of typical blocks, not anticipating the time requirement for the surgery,
yep,
or giving narcotics as part of the anesthesia, then the patients are going to be it's going to be more difficult to wake up if they're fluid overloaded. And so all of this, to really win coming up, you're managing this from initial contact from anesthesia. And so as we do, we don't, we have our own anesthesia team, but, they don't give narcotics. They give the necessary fluid, very careful not to overload. And that's
yep.
that's how you get a knee replacement up and walking 45 minutes after surgery,
Yeah, yeah,
and
yeah.
through the program.
So if I were to summarize for the people watching sort of the key elements to minimize the post-acute or after the surgery cost savings in the bundle, and it also improves care, in my opinion, the data is very clear on this. You minimize the patients who you have to send to a rehab facility. You minimize any unnecessary interventions like physical therapy, and the patients can recover on their own. And then the third one is be mindful of that time period right after surgery to make sure that you can stay really good contact with your patients. If they do have an issue, they don't just go to the emergency room or they don't go to a hospital. We do the things on our end to make sure they're not hypotensive or lightheaded, but then you don't want them going back. So do you think that we can manage, back in the original CJR, we had to manage that part of it, that piece of it. They had what's called nurse navigators, but those are expensive. People are expensive to hire in a medical practice. Do you think we can accomplish this digitally? So do you think some of these new digital engagement apps, right, that communicate with the patient if they use it, like they say, "Hey, I'm lightheaded," and that's a signal, and we're like, "Wait, just talk to us. Come to the office. Don't go to the emergency room." Right? Do you think
No,
that can
yeah,
help?
absolutely. And there's some vehicles out there that provide that, but gone, or and there's such a wide shift, right? So at 4 o'clock on a Friday, our
Yeah.
office, we're telling patients, "Oh, we're closed, so just go to the ER or urgent care." And what we need to do is retrain patients to engage in the technology. And something that's changed from the original CJR, um, uh, we were working on the patient-reported outcome measures, and we were literally sitting in meetings saying, "Okay, so it's going to be an app on the phone." And if you think about 2016, an app on a phone, right? So people would say, "Oh, old people," of which I'm now one, old people don't have phones, or old people don't are flip phones, or they don't have no idea how to open an app. And now, if you walk around our waiting room
Right.
at 2 o'clock in the afternoon, you just see everybody with
On their phone.
their phone. So the and with the location services and all of the things, I
Yeah.
feel strongly that soon we're going to be able to tell when a patient does make an encounter and intervene, even if a patient is in another city and they're in an emergency room, waiting room. Wouldn't it be great if we could know what an invasion of privacy that would be? But wouldn't it be great if we could find out? Because the reality is, once you have an encounter, nobody knows. So a hip replacement of yours could go to a health system 20 miles away and be admitted for 10 days.
Yeah. Right.
And if nobody in the family calls you, and if the hospitalist is treating the pneumonia but doesn't call you, we don't know.
That's
And
right.
the 10-day inpatient episode lands on your lap or
Yep.
the hospital's lap. And so having an app where the wife can just hit a slide bar, or the husband, spouse, and just say, "Oh, we've had an encounter," and then allow our nurses
Yeah.
or PAs to call the patient and say, "Hey, there's an issue," and that would really streamline healthcare in this
Yeah.
area.
Yeah. Yeah. So I get a quick Mark Copeland on there says, can you repeat your post-op protocol for total hip arthroplasty in young patient? Sure. It is basically no physical therapy. They get an anti-inflammatory. We use Celebrex, and we've been exploring the non-opioid new pain medication. I don't have a conflict with it, but it's called Jornavix, and Tylenol. So they get those three medications, anti-nausea, and if they need it, and we keep them euvolemic in surgery. I think that's a really important point, because we went through phases where people would have people drink a lot of Gatorade before they came to the hospital, because when Mayo Clinic published the data on you could drink clear fluids up to 2 hours before the surgery, we thought, okay, get them hydrated. But what we realized, you could overhydrate people and then they could have urinary retention. You want to avoid that. So we'd keep them euvolemic. We don't force them to drink water. We allow them to drink up to 2 hours. And that's been a game changer for us. That's really it. And then we just tell them to walk, right? So we don't have any restrictions anymore. Tell them to walk, go home, recover, call us if you need anything. There's exercises in our app. We use Hopco, the Health Outcomes Performance Company. We work with them to do our postoperative app called My Recovery. Sends them exercises to do at their own at their own pace, really. And I tell them, if it hurts, don't do it. So that's. I mean, if you think about the episode, Tony. I mean, if you think about cost savings, like all the stuff we used to do, keep people in the hospital. Like when I started in practice in 2005 and started on my own. That doesn't even count during residency and fellowship. We kept people in the hospital 3 days. I don't know, 20% of them, 30% of them went to a rehab facility for another wherever, and they all had therapy. I mean, the
Right.
amount of resources we were spending, and I think the new era of healthcare, Tony, for value-based care, one of the era is simplicity. I really think we have overcomplicated, and we understood hip and knee replacement was a big surgery, cutting the ends of bones off, and everybody's like, "Oh my gosh, what's look what we're doing to these patients," and we keep them in the hospital, watch them for. We probably caused the majority of the complications. Now we didn't have tranexamic aspirin, but we probably because we made. I tell people, you're laying in bed for 3 days. Oh, you might get a blood clot. Of course you might.
Right.
When you
Right.
go home, you got to get up. You got to get up to feed yourself most of the time, right? You got to get, especially because your spouse only will do it for so long. Like you get your bologna sandwich or whatever, right? You got to get out
Well,
of the bed.
it's all part of a cultural shift.
It is. That's right.
So
That's right.
my mother was in the hospital for a week after she had me, and I just had a grandchild, and 24 hours, and they're just, let's go, everybody
Yeah.
out. You're
Yep.
good. You're good.
Yep.
And
Totally
so,
true.
and it's that bite back on culture. Every time you want to change the culture of something, the headwinds are high.
Yeah,
And
that's right.
so,
That's right.
I
That's right.
think I think that's our challenge in front of us is there's still way too many people in administrative positions, managing hospitals, that group,
Yeah.
physicians that have not bought in,
Yeah.
that are not embracing these new issues. And I think
Yeah.
that's a
So let's switch gear. I want to ask one more question. Let's talk about the concept of gain sharing because orthopedic surgeons, hospital administrators, groups, leaders, etc. The concept of gain sharing that the government has said in this CJR program is legal when it used to be prohibited. Walk us through the concept of gain sharing and how that works in these bundled models or CJRX.
Well, that's a deep trove of information, right? Because there's so many different ways of doing this, and there's so many different groups that you could gain share with. We happen to believe that since it's the surgeon that initiates the episode, that I would advise gain sharing with the surgeons. And it's the surgeons that can pick and choose the anesthesiologists. If I was involved with this, I would have a core team of anesthesia providers that I saw eye to eye with, and I had history with, that would provide that and minimize my risk of a re-encounter in the first week as best they could.
Yeah.
So under that model, if I'm saving the convener a certain amount of money, that money would get pooled, and the hospital would take a large chunk of it. But ideally, we would want the hospital to say, but, and by the way, what we've not mentioned is that unlike other programs, the quality program of value-based care within CJRX, although it looks at quality metrics, and you have to hit these metrics in order to get your reimbursement.
Yeah.
But in order so you have that quality, but the money that you get is really new money, and the money that you owe the government, that those are new funds as well. And so unlike other things that physicians are used to, where they withhold 20% of your money, and if you're a good person they give you 18% back,
Right.
with the value-based care program, and hospitals can set it up any way they want, but the way we've set it up in the past and what we're planning for in the future with our hospital partners is that money is divided, and that's new money both to the hospital and to the provider. So that's an incentive. And this gets back to cultural change. If I'm trying to get somebody's attention and I need a behavior out of that person, we can do it because I'm a good person and it's good for the patient. Or if it's extra work and I need them to pay attention and go to meetings and not just let people who don't care send patients to various therapists that don't have good outcomes and all of the things we've been talking about. If I need somebody to pay attention, there's a price for that. And I think CMS has finally recognized that. DOJ is ducking out of the way, saying, okay, do it.
Yeah.
And so it's really just getting that relationship. And I'm going to be at a mid-sized hospital where they've never been involved in a value-based care program. And we're going to set up a program. And if I'm going to get 5 orthopedic surgeons to suddenly start paying attention,
Yeah.
and it's the margin, I don't care if it's diamond encrusted
Yeah.
plant or whatever. It's the post-acute care that matters. And if I'm going to get them to pay attention, then it's going to be some money. And so some amount of that money gets sent to the physician. Now, there's some rules and restrictions, and not to get into the weeds, but that's where that comes from. And that's
Yeah.
the sharing.
Yeah, in general, we can go back 10 years when we did it together. You and I did it together at our prior healthcare institution. The gain sharing pool of the money saved, 50% went to the hospital. Some could argue that's a little too much, but you and I would argue that's too much, is what it is. And then 25%, I believe, roughly, went to an education fund to give to nurses. We would help send them to conferences, whatever. And then 25% went to the surgeons. And the interesting thing about gain sharing in these models is when you put the quality piece in, you can also it's also compensated by volume. So it's volume and quality. So the busier surgeons can get bigger checks because they're doing more work and saving money, and that gets shared accordingly. And I remember that was a successful way to do it. But the concept for the people on the that are going to watch this, both live and in the future, the concept of gain sharing is you pool that money that you save with the convener, who now it's the hospital, and then you split it up. And to your point, Tony, when to get physicians and programs aligned, that financial incentive has to be there, right? I think you would agree with that, right? That alignment is key.
Absolutely. Absolutely. And
Yeah.
the sharing with the nurses, both on the floor and in the operating room, they're really part of the
Yep.
process.
Yep.
And it's uncommon. The first thing that gets cut when net revenue falls from 9% to 3%, and everybody's in a panic at a hospital, the first thing that gets cut is education funds for nurses. Frankly, it just seemed like that was automatic.
Yeah.
So the fact that we built up a chest of money for them to get their
Yep.
NEs and all of the things that,
Yeah.
and they help. They're making us
Yep.
more efficient in the operating room. They're taking care of the discharge stuff. They're making us aware of potential problems
Yep.
before patients discharge. So it really is
Totally
critical.
agree. Great. So we're at 31 minutes. I'm going to do one more question that's timely. Mark Cuban's coming out, making a lot of waves about eliminating the PBMs and the commercial payers, et cetera, and going direct to employer. Walk us through a little bit direct to employer and how you see that evolving in the next, few years.
Well, um, that's another area that has a lot of different
Yeah.
definitions and connotations. I think Mark is really disgusted with the the quarterly revenue reporting of the
Yes.
top 20 businesses in the United States, and I may get this wrong. I think 6 of them are health insurers. It's just ridiculous the amount of money being raked in. And so, in general, the direct to employer model is the employers can get price transparency directly from a health system in that setting. They know exactly what something's going to cost, and then the employer can make choices. Am I going to go to hospital or health system A or B for my 5,000 employees that gets, 4 knees and 2 hips a year, a couple gallbladders come out, but at least the employees will know this is what there's transparency and this is what you're going to get charged. And essentially, it takes the payer out. That money is exchanged between
Directly.
Mark's company and whatever. In Indiana, where we are now, we're a test state where the state, I'm not saying they're looking at what Cuban did, but Cuban is definitely looking at what Indiana's doing, as is
Yep.
California, New York, and
Yep.
several others. But
Yep.
the governor here has made it mandatory that big health, the 5 major health systems in this state, have to have a direct to employer relationship. Which in this setting in Indiana means that all the services for an institution have to be exposed, prices transparent, and they have to have, at least as I recall, one relationship, one employer. They have to document that they've done it, that they've done
Yep.
something. Because the price transparency in the past, the health system would have 25 million lines of code that nobody could decipher, and they would publicly report it.
Yeah.
And
Yeah.
you never knew what was going on. So in Indiana, it's become explicit. You have to do it. And then coming soon in September of this year, the mid-size and smaller hospitals, acute hospitals, have to do the same. And so there's a lot of rushing around right now to try to figure out how to manage these. And for us as a specialist, we have the ability to go direct to employer as well. Obviously, just for orthopedics, we can carve out hip and knee replacement, ankle replacement, and have a separate contract with an employer just to cover that piece. And so this is an exciting time to kind of short circuit the traditional mantra, again, culture change
Yep.
of waiting for people to pay their um, health insurance bill, and then they get a huge deductible, and then they get denied service, and then it just goes on and
Right.
on.
Right. Right.
That's not working. We can all agree to that. So
Yeah.
something has to
Yeah.
change.
Yeah. I think it's great. And I think Tony, you and I'll maybe try and do these a little
All right. Well, we lost Michael. All right. Let's see. We lost you, buddy. All right. Mike's computer died, so we're signing off. And we'll do another one of these in a month or so. Thanks for tuning in.